Hi, everyone. I'm Enrico Asher, Executive Director of the Frank J. Veith International Society. I'm honored to introduce this webinar on topics selected from the Low Frequency Disease Consortium. This is a singular program created and developed by Dr. Peter Lawrence. Dr. Lawrence is a past president of the Society for Vascular Surgery, former chief of vascular surgery at UCLA, and former editor of the Journal of Vascular Surgery. This project rapidly became the most reliable source of information related to the natural history and management of vascular diseases that are not so frequently encountered in one's clinical practice. Peter kindly accepted our invitation to put this program together and to co-moderate this webinar with Dr. Jessica Simmons, who is a superstar academician and an associate professor of surgery at the University of Massachusetts Medical School. Unfortunately, Dr. Simmons was called for an emergency surgery, and she hopefully will be able to still join us before the end of the webinar. Dr. Keith Caligaro was from University of Pennsylvania and Chief of Vascular Surgery at Pennsylvania Hospital, was kind enough to replace her. Peter will also give a talk, Peter Lawrence will also give a talk on renal artery aneurysms. Prior to handing the microphone to Dr. Lawrence, please allow me to make some quick announcements. The Frank J. Veith International Society is running its third annual competition on innovations in vascular surgery and endovascular therapies. If you or any of your associates would like to take advantage of this event, please go to frankjvsociety.com to submit your abstract or your colleague's abstract. It's very competitive, this program, but the award and the exposure it provides will be a major boost to your innovation. An important reminder, registration for the November Veith Symposium has begun, and this year is a special year because the Veith Symposium is celebrating its 50th anniversary. Don't miss it. It will be an unforgettable event. Once again, the Frank J. Veith Society now will run 2 sessions at the Associate Faculty Program during the upcoming Veith Symposium. Please go to www.veithsymposium.org to submit your abstract. And please select the Veith Society option on the screen so you can be part of this another competition that will be running. Today, we are fortunate to have a faculty of internationally recognized surgeons, some presenting their interesting work and some discussing the presentations. Also, we are honored to have with us the man who inspired the creation of this society, the legendary Dr. Frank Veith. Thank you, Frank, for being with us today. Last but not least, let me introduce to you another legend in vascular surgery, who soon will be our 4th president, Dr. James Stanley, a recognized leader in vascular surgery, the ultimate academician and a superb surgeon who marveled us for many years with his great achievements. Welcome, Dr. Stanley. It's a pleasure and an honor to have you lead our society. Without further delays, I'll pass the Zoom microphone to Dr. Peter Lawrence. Peter?
Well, thanks very much, Enrico, for both inviting us to present on the Low Frequency Disease Consortium. And it's always a pleasure. And Frank, this society and Jim Stanley, the upcoming president, it's a real pleasure to talk to so many people about something that's been almost a little over 20 years in the works. I'm not going to go into detail about the Low Frequency Disease Consortium, but what I will say is that probably a little over 20 years ago, I realized that we had great databases, and VQI and NSQIP looked at common vascular diseases, but essentially we had very little way to understand or to reach consensus on what we call low frequency. These are diseases where no single institution has enough of an experience to publish their own experience or their own research paper, but they're frequent enough that we see them. And we estimated when I moved to UCLA 18 years ago that about 30% of our practice was these uncommon diseases. So this database is a way to put together people. It started with only 2 or 3 institutions, and now there are over 120 institutions. There have been over 500 physicians involved in it, and many thousands of patients who have participated or had their data entered into the Low Frequency Disease Consortium. At the end of my talk, I'll give a website where you can look at and determine whether you would like to participate. This is open to all. It's not an exclusive society. The only thing we ask is you have a commitment to giving us accurate data and fully participating in the study. So with that, I will turn it over. Our first talk is by Mario Doro, and Mario is actually speaking to us today from Italy. And so he is going to talk about the aberrant subclavian artery. This is an idea that actually he proposed to the Low Frequency Consortium several years ago. And so it shows how this has become a truly international program. And Mario, why don't you take it away and tell us about the one or two projects that we've done related to that in your leadership role as an author.
Hi. So first of all, thank you very much for having me here. It's really a great pleasure and my biggest honor to be here. I will share my screen now. So my talk will be on the outcomes for treatment of Commer's divertigulum and aberrant subclavian artery. And we all know that aberrant subclavian artery aneurysms are a rare disease process, and they can occur with or without an associated Commer's divertigulum, but they can also include other associated aortic anomalies, such as, for instance, a right-sided aortic arch. And indeed, the current literature about this disease process is quite heterogeneous, as the estimated incidence is approximately 0.2 to 2.5% in the general Western population. And if we just have a look at the more recent systematic review on this disease process, we can see how much the literature is sparse. And indeed, in this review that was published in the European Journal just 2 years ago, we see that the quality of evidence was generally low, and 286 studies just included less than 4 patients. So we really see that we needed a large and multicentric study on this process. And in fact, we all face some issues for treatment, since this is a rare disease, as I said again, and we have no dedicated RCTs, no specific guidelines, and therefore the approach to treatment is not standardized. And we presented the preliminary data at VAM last year, but the full data were just published this year in the Journal for Vascular Surgery, and I'm gonna show you the final data. Overall, we were able to include in this collaboration 285 patients with complete data that were treated in a decade between 2010 and 2019 from 26 institutions worldwide. And you can see that the most common indications for treatment were symptoms in about 67% of the cohort and size in about 39%. Overall, the mean age of the population was 56 years with a mean BMI of 27, and there was quite half and half between females and males. The mean diameter of ruptured and non-ruptured aneurysms was 47 and 43 millimeters, respectively, and the right-sided arch was present in 23% of the cases. You can see also that 65% of the cases were treated with a totally endovascular or more commonly with an hybrid approach, and 35% of the cases were treated with totally open surgery. Overall, the mortality at 30 days was 5%, and you can see there was a big difference between elective mortality at 2% and mortality under urgent presentation, 17%. You can also see that the symptom relief at 1 year was estimated in 76% of the population. Looking at survival with Kaplan-Meier analysis, the survival status was reported for 241 patients, and at an average follow-up of 84 months, 88% of patients were still alive. While looking at the patency of the subclavian reconstruction, we had complete follow-up data on 142 patients, and again, at an average follow-up of 84 months, primary and secondary patency were estimated at 91 and 96% respectively. We were also able to perform some multivariable analysis, And you can see here that having an urgent operation was as a risk factor for mortality, for developing any intraoperative complication, and for having a longer length of stay. And you can also see here, very interestingly, that being of female gender was associated with higher odds for intervention. And lastly, we were also able to determine that the mean size of symptomatic aneurysms was 44 millimeters. So in conclusion, we have seen that hybrid repair has been the preferred contemporary approach, and that good symptom relief can be achieved with any treatment approach, and that open and endovascular or hybrid treatments seem to be similarly safe. However, receiving an urgent operation seems to impact the morbidity and mortality of the operation itself. Also, we were able to show excellent subclavian patency rates at midterm follow-up and reasonably low reintervention rates irrespective of the index treatment modality, although female patients may be more at risk for reinterventions. And also, I want to say that very recently, we just had the second paper accepted in the Annals of Vascular Surgery, specifically looking at the comparison between the right-sided and left-sided aortic arch anomalies. And with this, I thank you very much for your attention.
Thanks very much, Mario. Great presentation and a classic example of an uncommon disease. Dr. Veith, comments?
Well, my comment, I guess, reflects what you just said, Peter. First of all, Mario, that was a superb presentation. And Peter, I really think you deserve great credit and positive feelings about starting this consortium, because on a disease like this, the value of the consortium is there's no substitute for it. So it's one of the major contributions of the decade to vascular surgery. But Mary, I guess my burning question to you, everything in vascular surgery over the last 20 years has seen an evolution from open to endovascular treatments. And where do you think on that spectrum we now stand? In other words, are we moving more and more toward endovascular parts, components of the reparative procedures, or do you think we've reached the final analysis? It seems to me that in general, we're moving constantly toward more endovascular. And I just wonder if that's true with the comorals and the subclavian aneurysm.
Well, yes, I think we are moving toward endovascular, but I also want to say that at least in this cohort, the total endovascular treatments were really a few, about 20 or so, and done in the latest years. And the most commonly performed approach was hybrid, meaning subclavian transposition or bypass plus TIVAR. And also I saw another question in the chat that reflects why the overall mortality for total endovascular or hybrid approach was higher. And I think that reflects also the difference at baseline between the patients who received either treatment, because on average, those who received open treatment were younger, and also they were more commonly treated on an elective basis, while those receiving hybrid treatment, they were more likely to be older. So there is also some difference in the baseline characteristics of this population. So I think the hybrid repair is here to stay as the most common treatment approach. But of course, as the experience with total endovascular treatment of the aortic arch increases, I think we will see more and more treatment also for these rare diseases. Although of course the complexity of the anatomy might not easily lend itself to total endovascular treatment.
But Mara, just to follow up on that, you say the total endo had a higher mortality?
Overall, total endo and hybrid had higher mortality, yes, without any simplification.
And do you think that will decrease with time as we get better at it and techniques are
that's one point, but there is also, I would say, a selection bias in the treatments, because those undergoing totally endovascular or hybrid, they were older on average by 10 years or something.
Great presentation.
All right, one quick question and quick answer, hopefully. When you treat with a hybrid approach and you have a large aneurysm and dysphagia, we've had a few patients that don't lose their dysphagia and they're still complaining. How do you handle that aneurysm that's thrombosed and is no longer pulsatile, but is still causing dysphagia?
So this is a very good, of course, observation. So if you look at the study, the overall relief from symptoms in 1 year was very high, reaching almost 80%. And there wasn't any significant difference between open or endovascular. So of course, I think we have all seen those patients with larger aneurysms and without disappearing symptoms with an endovascular approach. So I think in those with a very large aneurysm, it might be also, I mean, we could consider going for open, but I don't have a definitive answer right now.
Good. Dr. Asher, are we done with our time for this one?
Yeah, we are not timing. We just got to make a
Okay.
short comment and short answer, and we move along. Then we have time for further discussion.
Okay, Dr. Caligara will both introduce the next topic and speaker and also be the discussant.
Yeah, okay, so the next speaker is Dr. Frank Caputo from the Cleveland Clinic, and he'll be addressing in situ bypass or extra anatomic reconstruction for aortic graft infection without enteric involvement. Frank? Maybe. Yeah, Frank, I think you're on mute, Frank.
You would think by now, in 2 years of 3 years of being virtual, I would know how to hit the mute button. But anyway, I do want to thank for the opportunity to the invitation to talk about a area near and dear to my heart, which is aortic graft infections. Here's my disclosures. Aortic graft infections maintain with a high mortality perioperatively, as well as overall 5-year survival of approximately less than 50%. There is a lot of morbidity associated with 20% ultimately undergo amputation, and 60% perioperatively end up with pneumonia, renal failure, and cardiac complications. Abdominal aortic graft infection remains a major surgical challenge. There are several tenets that we have to know to manage this, and that includes resection of the infected aortic aneurysm, prosthetic material, and infected retroperitoneal tissue, and how to strategy we're going to take for restoration of distal flow. As we know, here is Hercules battling Cerberus during one of his 9 labors. And no one wants to be in the business of infected aortas for their entire life. But there are several strategies that help us maintain perfusion and resect infections. Extra anatomic bypass, autograft, and prosthetic allografts. These really are our treatment options. While there's 3 options, everyone has their pros and cons. Extra anatomic bypass is a high rate of reinfection. Patency is an issue. How to maintain a patient anticoagulation. And if the aneurysm deals with the visceral, how are we going to maintain perfusion to the visceral segment, the renals, and the intestines? Redo in situ bypass with or without infection impregnated. The chance of reinfection, and also the idea of chronic antibiotics. Venous autografts, otherwise named MACE procedure, as many of you have done this before, including myself, length becomes an issue. Diameter, as well as complications that are associated with the harvest of the deep vein. Along the same lines, cryopreserved arterial allografts or venous allografts. There's a delay in getting such the material, the expense of which, and how are we going to preserve it. And just to give you an idea of Dacron, which has become into favor quite a bit in situ, there's often a role of why we would use this. So here is just several series, and I think this is where the very low frequency database really comes into effective. There's several series out there looking at all sorts of different strategies, but the numbers, as you can see, are quite low. So when we look at graft excision and an ex situ bypass here, what you see is that, oh, there's several series, you can see that survival at 1 year is anywhere between 50 and 80%, which is a very wide range with, results of morbidity, including not just limb loss, but also the catastrophic stump blowout. And we look at in situ bypass, depending on what you read in terms of the series, again, the series numbers are between 29 and about 190, and survival ranges from about 70 to 100%. So just to go over some of these single series studies, here we have a paper, and this is probably not to be remiss of the classic papers of Linda Riley and Pat Claggett talking about staged extra-anatomic or the NACE procedure, but a more contemporary series would be that from Mayo, looking at retrospective review with 117 graft infections, where they compared their in situ prosthetic reconstructions and their axillofemoral reconstructions. Primary outcomes measured early and late procedure-related death and primary graft patencies and limb loss. Secondary outcomes included your overall morbidity and patient survival, graft reinfection rates. And if you look, compared to the in situ had much less morbidity and actually had less amputation as well as less death from any cause compared to the axillofemoral. And this can be seen here as being highlighted. So in addition, we look at studies looking at recurrence of infection with an aortic graft infection who underwent in situ revascularization with a silver-coated prosthetics or looking at antibiotics. We could also see that there was also, while there are perioperative complications, the freedom from recurrent infection was almost 100% and 92% at 3 years. There was no instances of late graft occlusion, and there was patient survival rate of 75% at 1 year and 62% at 3 years. When we look at extra-anatomic reconstructions in the contemporary series, you can see that they had much higher rates of amputation as well as operative mortality compared to the in situ rate. And when we look at cryopreserved homografts versus silver-coated or antibiotic Dacron-coated, while they did have similar results,
Can't talk about going back.
the salvage rates were similar as well, the graft patency rates and the mortality. There was cost of therapy, you could look compared to $42,000 of the cryopreserved versus the $15,000 in our Dacron served. Here was an example of their algorithm they did use in order to determine whether or not in situ was an option for them. Now, when we look at all these series, we look at they're all very small series and very limited in terms of data. And if you look here, here is a paper that is out of the Vascular Low Frequency Disease Consortium with Dr. Smeds as the lead author. And it looked at endograft infections, which is becoming much more common in 206 patients with EVAR of 180 and 26 in TVAR. And just to give an idea, which I think is an important question, where are these sources of infections coming from? And it's not just necessarily native infections, but contaminant and procedures that happen as a result of endovascular leakage. But just give you an idea of what they did. They had 206 patients, 180 EVAR, 26 TVAR, 197 patients required surgery, and they underwent either in-line reconstruction. The majority of patients are extra anatomic with cryoallograft and NICE, making up 54 patients and 21 patients respectively, and prosthetic 83%. So for this paper, the cryoallograft and the NACE were considered the autogenous population. If we look at it, the operative time was highest in the allograft and the NACE procedures as compared to the extra anatomic as well as the in situ prosthetic bypasses. Perioperative mortality was highest in the extra anatomic group. However, there was also the lowest numbers of procedures performed, so might be a selection bias there, and the complication rate was the highest in extra anatomic bypass. In terms of in situ, they tended to have the lowest rate of complications. However, when comparing in situ of autogenous versus prosthetic, the highest mortality was that of the prosthetic versus the autogenous, which included the allograft as well as the NACE procedure. So when is Dacron appropriate for infected aortic grafts? or in situ, it'd be availability, ease of use, and able to do complex revascularization if needed. The one thing I would say is one of the limited things from the vascular low frequency papers are when they mention Dacron as being inferior to autogenous, they do not mention the omental wrap, which I think is probably been the #1 adjunct for the in situ Dacron, and the rifampin soaked, obviously. So just to give you a little crosshairs between extra-anatomic and situ prosthetic, as well as your allografts, is extra-anatomic has a higher rate of limb loss compared to your inline reconstructions. Your mortality tends to be associated with your in situ prosthetic and your venous autograft, although you can see the wide range depending on the series that you read. And the reinfection rate is highest in your extra-anatomic bypass. I want to thank you for the opportunity to present this. I'll take any questions.
Great, thanks very much. And Dr. Calagaro, your comments?
Yeah, Frank, very nice review of this topic. I guess, you know, I certainly applaud the efforts of the Low Frequency Consortium. I think it's a great organization. But the problem I have is, especially with this topic, is the retrospective nature of the studies. And I got to tell you, I'm not sure we're ever going to come up with a real conclusion to what is best to treat infected aortic grafts. And real briefly, I mean, I know if I have a patient with an absolutely horrible heart who will not tolerate aortic clamping, I'll do an Ax-Bi-Fem first to offload the heart. But you're selecting out bad risk patients who get Ax-Bi-Fem bypasses. So my question, and it's probably going to be a pretty brief answer, and I think I know it, Frank, but do you ever think there's going to be some kind of a randomized trial to treat infected aortic grafts?
No, I mean, I guess you could foresee, I think there's a lot of data coming up about tubularized bovine pericardium being used. I have not personally used it. And people are talking about doing a randomized trial with that in terms versus, but no, I mean, there's no good answer with an infected aorta. You get an infected aorta, I mean, if there was a great answer, we'd have it by now, right? So everyone is kind of choose your own adventure when it comes to strategy. So.
Okay. All right. Thank you. Peter, you're on mute, Peter.
Yeah, Dr. Keller, you want to introduce the next speaker? Or would you like me to? That's right, I can do it. Next speaker is Donald Barrow. When he was at UCLA, participated and led a study in the management of peripheral venous aneurysms, multi-institutional trial, and Dr. Barrow is now at Cedars-Sinai Medical Center. Donald, welcome.
Thank you, and thank you to you and Dr. Asher and Dr. Veith for the invitation. So as you heard, we'll be discussing peripheral venous aneurysms. Just confirm that that's advancing. So I have nothing to disclose relative to this. So as we know, peripheral venous aneurysms are rare pathology. They're described in less than 0.5% of patients with a known venous disorder. They present primarily in the lower extremity, and the morbidity is associated primarily with thromboembolism. Previously, there are about 80 plus case reports over the last 70 years. The largest study in a single series was this one, which included 30 upper and lower extremity aneurysms. 20% of these patients presented with DVT and PE, and all of the patients in this large series were treated surgically. More recently, there have been some meta-analyses describing a PE risk somewhere between 25 to 50%. Obviously, a significant variation in the diagnosis and treatment of these aneurysms, and no real consensus on the management. So the objective of our work was to describe presentation, natural history of these peripheral venous aneurysms, and evaluate the modern management and outcomes of venous aneurysmal disease. As you've heard, we use the Vascular Low Frequency Disease Consortium, has been outlined previously. For this particular study, there were 11 centers from around the world that contributed a total of 66 peripheral venous aneurysms. This included 7 US centers as well as 4 international institutions. As you know, this is a retrospective but multi-institutional view. This was done in a contemporary series over 10 years. Inclusion criteria included both upper and lower extremity venous aneurysms. Aneurysm defined as aneurysm greater than 1.5 the vein proximal or distal to this. Excluded were pseudoaneurysms, arteriovenous fistula associated venous aneurysms, and varicose veins. This is a standardized data collection online. All these aneurysms were identified via cross-sectional imaging or duplex ultrasound. Data specifically regarding size, morphology, and the presence of mural thrombus were captured. Looking at the demographics, these aneurysms were distributed evenly between males and females. Patients had a mean age of 54, relatively normal BMI. About 40% had a smoking history, and of note, nearly 1/4 had some degree of trauma history to the area of concern. There was no significant family history of either venous or arterial aneurysm disease that could be captured. The distribution of the aneurysms included 40 popliteal aneurysms, 14 iliofemoral aneurysms, and 12 upper extremity or jugular aneurysms. With regards to clinical presentation, 16 of 40 popliteal venous aneurysms were presented with pain, 3 presented with deep venous thrombosis, and 4 presented with PE, while the remainder were discovered as incidental imaging findings. Amongst the iliofemoral aneurysms, 6 presented with pain or swelling, 3 with DVT, and all of the upper extremity or jugular aneurysms presented with clinical signs or symptoms. In terms of morphology, in the popliteal location, 25 of the aneurysms here were fusiform. However, in the upper extremities and iliofemoral locations, saccular morphology was far more common. With regards to thrombus, 35 of 40 aneurysms in the popliteal location had a thrombus burden less than 25% of the aneurysm lumen. Of those in the iliofemoral location, 6 or 43% had thrombus burden greater than 25%. And in the upper extremity, 4 of 12 patients had thrombus burden greater than 25%. Amongst the popliteal venous aneurysms presenting with PE or DVT, this was associated with the larger aneurysms. Specifically, the average size of an aneurysm that presented with DVT or PE was 3.8 centimeters compared to those that presented without thromboembolism, which was only 2.5 centimeters. Regarding the risk of luminal thrombus, 45% of saccular aneurysms had thrombus burden greater than 25% of the aneurysm lumen versus only 3% of fusiform aneurysms. Also, thrombus of greater than 25% of the lumen was significantly associated with presentation with DVT or PE. In terms of initial management, half of the patients were treated non-operatively, while half of the patients underwent operative interventions. 20 popliteal aneurysms, 6 iliofemoral, and 6 upper extremity aneurysms were initially managed non-operatively, and 8 patients from the non-operative group did go on to have an operative intervention. Taking a look at the patients treated non-operatively, 6 of these were managed with anticoagulation, 8 with antiplatelet therapy, and 19 with observation alone and no antithrombotic therapy. Of the patients that went on to surgical intervention of this non-operative initial group, the indication was pain in 3 of the patients, new DVT in 2 patients, and absolute size in 3 patients. With regards to non-operative management and growth over time, in the iliofemoral group, there were 2 aneurysms that demonstrated growth over an average period of just over 3 years. 1 upper extremity aneurysm grew over the course of 2-year time period, although no popliteal venous aneurysms exhibited significant growth over an average follow-up period of almost 2 years. With regards to thromboembolic risk of those patients that were treated non-operatively, 1 patient with a popliteal venous aneurysm did develop DVT while being managed with observation alone. 2 patients who were reportedly therapeutic on anticoagulation with iliofemoral aneurysms did develop DVT. 41 total patients, including those that crossed over from initial non-operative management, underwent surgical intervention. The most common indication was absolute size. Average size of aneurysms treated for this was 3 centimeters for popliteal, 5.5 for iliofemoral, and 2.5 in the upper extremities. 7 patients had surgical intervention for finding of DVT, and 3 patients who had originally presented with PE. The most common surgical approach was aneurysmorrhaphy in 51% of patients, followed by excision and ligation. Those patients who underwent interposition bypass, small saphenous vein was most commonly used for popliteal venous aneurysms, and contralateral femoral vein in those with iliofemoral aneurysms. Postoperatively, 6 patients were managed with antiplatelet therapy alone. Nearly half the patients underwent anticoagulation for a mean of just over 7 months. With regards to postoperative complications, 10% had hematomas requiring reintervention. Infection was rare, and there were no postoperative deep vein thromboses or thromboemboli, and no reported post-thrombotic complications in a follow-up mean period of 27 months. So in conclusion, lower extremity venous aneurysm and those with thrombus burden greater than 25% of the lumen are much more likely to present with thromboembolic complications than upper extremity aneurysms. The thromboembolic rate amongst our cohort seemed to be comparable to prior series. Surgical intervention appears to be indicated in symptomatic patients, most often performed by aneurysmorrhaphy. Postoperative anticoagulation for approximately 6 months seems to be sufficient to reduce the risk of any recurrent thromboembolic events. And certainly further studies should be done to clarify the contribution of aneurysm size on thromboembolic risk. Once again, thank you for the opportunity. And thanks to Dr. Rashid Patel, our former resident, who's now up at OHSU, Dr. Wu and Dr. Lawrence, and all the contributors to this study.
Great. Thanks very much, Donald. And we're going to move to a discussion by Ross Milner, who's the Chief of Vascular Surgery, University of Chicago. By the way, this is one of the few venous low-frequency disease studies, but one that we thought was really important to study. Ross?
Yeah, thank you, Peter. And as always, Dr. Veith and Dr. Asher, appreciate the opportunity to be involved. And Peter, to you and your team, this consortium is so valuable for all of us. And I agree with you. This is a very important venous topic. And I appreciated you guys including me because it gave me an opportunity to look at the paper again and learn. So thank you. Don, great presentation. 2 quick questions that I think will both be able to be answered with similar thought process. So as I thought about it and listened to your presentation, was trying to decide in my mind whether size is the appropriate indication for repair or thrombus burden or both. And then secondarily, if you're not going to repair, it wasn't very clear to me what the surveillance paradigm should be to look for increasing thrombus burden or increasing size. And maybe it's just not clear because we don't see those enough, but those are my 2 questions for you, Don. Thank you.
Yeah, thanks, Dr. Milner. Yeah, I mean, I think it's a combination of size, and then I think what we saw here, thrombus burden. I think that's the one thing that we learned here, that one, saccular aneurysms have more thrombus burden, and thrombus burden for sure does appear to be associated with the thromboembolic complications. So I think when you see lots of thrombus, just like in perhaps a popliteal artery aneurysm, I think we'd recommend treatment even if size hasn't reached a threshold. That being said, it does look like, these over 3 centimeters, the larger aneurysms are associated, one, with complications, but certainly often more associated with symptoms that the patient might want to have something performed for. I think in terms of, whether or not to treat these incidentally found that have no thrombus, the patients are asymptomatic, what's the annual surveillance? And again, I think unfortunately, even with this study, our numbers are low. And, what are the surveillance recommendations? I mean, I think it's simple for most of these, see these with duplex ultrasound. I think we showed that not necessarily treating them with anticoagulation is a benefit unless they do have all that thrombus within them. So I think sort of annual surveillance with duplex would be our recommendation, but probably a little more science needed to back that statement.
Great, thank you so much.
Okay, we're going to move on, and the next speaker is actually our moderator. Dr. Peter Lawrence will be addressing the natural history and contemporary management of renal artery aneurysms. Peter. And you're muted again, Peter, I believe. There's a course we're offering, how to work a Zoom conference that Dr.
There we go. There's the unmute. Sorry about that. Let me go to the beginning. Okay, can you all hear me now?
Yes.
Good. So I was asked to talk about the renal artery aneurysm study that we did, and Don Coleman and Jim Stanley, who'll be discussing this, were two major contributors to this. So we have no disclosures, or I don't personally. As most of you know, if you look at a textbook, you'll see that these are the indications for repair of renal artery aneurysm, symptoms, and then size, and in childbearing and pregnant women. But there's a lot of debate about this as to whether or not these criteria hold up. There are several papers that have been written on this, and this is one that said that size does not matter. And we have a very important study that Peter Henke did, but it was over a period of 35 years and published in 2001. So even before cross-sectional imaging was used routinely, that said that the criteria should be an aneurysm that was greater than 2 centimeters. So there was a lot of discrepancy and debate. Consequently, we conducted and did a low frequency disease consortium on renal artery aneurysms, and this was primarily in the United States. Here you can see the institutions that were involved in this study. And we were able to identify through this group of people 759 aneurysms and 650 patients. The presentation of the aneurysms was primarily hypertension. I'm not sure why my slide is moving ahead. Was primarily hypertension. When we looked at the clinical presentation, the majority of these patients were asymptomatic, but the second most common clinical indication was hypertension. The aneurysm location was something that was of interest to us, and as I think you can see here, as all studies have always shown, that it's more common on the right than the left, but also the ratio of the bifurcation, which is where the most common with a saccular aneurysm of the bifurcation, followed by the main renal artery, and then lastly by branches or intrarenal, where the location of aneurysms with these numbers. The morphology is also something that's been interesting to people who have studied this frequently, and whether it's saccular, which occurs in patients, fusiform, or associated, an aneurysm associated with fibromuscular dysplasia. The characteristics of the aneurysm, when we looked at it, in this group, the large majority were saccular and primarily at the bifurcation, and that was the most common. But the other thing that we thought was very important was the number of vessels that were associated with the aneurysm, since if these are not repaired, there's concern about infarction of sections of the kidney. And here you can see that a significant percentage had at least 1, 2, or 3, and only 18% had no outflow vessels. Those were obviously ones of the main renal artery. The other thing is that it was about a 50-50 ratio between calcified and non-calcified. If we look at the initial evaluation and with the patients, we find that they were divided into symptomatic and asymptomatic, with the majority being asymptomatic. Of those who are symptomatic, the large majority were repaired, but there are actually some that were observed, and that might be in someone with hypertension, as an example. In the asymptomatic group, eventually patients underwent elective repair, and a small percentage, but the majority of them were observed. Here are the different kinds of repairs that can be done. This is from a paper that was written on the alternatives: patch, primary repair with reanastomosis of the renal artery, resection with bypass, reimplantation of branches, and then this one, which is actually Kathy Gallagher from the University of Michigan, which talked about an ex vivo complex repair in their experience. And lastly, endovascular stents, which have increasingly been used, but are usually limited to the main renal artery. If we look at the types of repair, you can see here that only 9% had an endovascular repair, and also can appreciate in the operative repairs that there was a pretty good distribution of different types of options, but that the key was that this almost always was a saccular aneurysm, the bifurcation that was taken care of in a number of different ways. And occasionally, even for the main renal arteries, you can see on the right, there's an interposition graft. The key here is that if a patient has an endovascular approach, their length of stay is much, much shorter, although obviously that only was performed in 9% of patients. As far as complications, the major complication, which is the left column, was particularly of concern in patients who were asymptomatic but had very large aneurysms. This is a group of patients, obviously, that did not anticipate a major complication. So that's a category that we think needs to be investigated further. One of the things that Dr. Stanley was interested in was the effect on hypertension, and you can see whether it's hypertension diagnosed at the time of workup or uncontrolled hypertension, about a quarter are cured, a quarter are improved. So in other words, 50% there's no change, but there is a significant improvement, whether it's uncontrolled or identified during the workup. The other key question is the growth rate. And here you can see on the right, the size of aneurysms over time, since many of these were observed, but the average patient has a mean of 1 millimeter of growth per year. If we look at freedom from repair in this series, about 80% of patients never required repair of their aneurysms. We were also interested in that group that were conservatively managed, how many ruptured, and in this series, not a single patient out of the large number that were treated had a rupture. The only complications occurred in patients and rupture in patients who were referred from an outside institution. And that was 3 patients, 0.4%, all transferred from an outside hospital. So not a single patient observed at the institution that participated in the study who was observed had a ruptured aneurysm. If we look at the conclusions from this study, we found that renal artery aneurysms very rarely rupture, whether they're 2 or 3 centimeters. Calcification doesn't seem to have an impact. The growth rate is very, very slow. And if we allowed aneurysms, rather than repairing them at 2 centimeters, to enlarge to 3, only 11% of the patients would require repair over 10 years. And then an important, I think, finding is that it can either cure or improve hypertension in more than 50% of patients who have renal artery aneurysms. So thank you for your attention. And if anybody's interested in participating in the Low Frequency Disease Consortium, this is the website where you can get further information. Thank you.
Yeah, Peter, is a very nice review. And, I think we'd all agree that the author who wrote the chapter in Rutherford is one of the most brilliant vascular surgeons in the, oh, that's me, by the way, I'm sorry. And when we were asked to review this topic by Rutherford, gosh, this is going back 15 years ago, we came up with the conclusion you guys did now, that you probably don't need to fix these things until they're over 3 centimeters. That really made a big impression on me. My question, though, is I have to say, when a patient is referred to me, though, with maybe even a 2 centimeter aneurysm, but it's really saccular, I get scared as hell looking at that. And it makes me hesitate to say, let's just keep an eye on it. And we'd all recognize, look, if you can treat it pretty simply endovascular, you may be more liberal treating these. But what are your recommendations when it's a saccular aneurysm? Are you still going to stick with that recommendation of 3 centimeters?
Well, as I say, there were no patients who had a rupture. I think everyone is concerned, and that's why the 2 centimeter criteria that Peter Henke published with Jim Stanley's group has been pretty much accepted, is because of the fact that it's concerning. I would say that in that case, I would sit down and talk with the patient. How complicated is the repair? And many of these, it's going to be at the bifurcations. It's going to require an open repair. How many outflow vessels are there? But I think that it just leads to a discussion with the patient. But I think you can feel comfortable in following most of these patients, even though they're saccular. So be interested in Dr. Stanley's comments, though.
So make just a couple comments. First, I was a co-author of this paper, so my criticism is sort of very almost a Zen performance, sitting in a room by myself, wondering why it didn't do some of the things I thought it would do. The one important contribution was it put rupture aside, and that's no question. The difficulty was that the main renal artery aneurysms, if there are mural aneurysms associated with medial fibrodysplasia, that's very different than a saccular aneurysm at a bifurcation of the main renal artery or a segmental vessel. So that I think that was an important recognition to me. And if we did it over again, it would be segregating those. So Peter, my two questions are that our experience really related to patients that were profoundly hypertensive and frequently had refractory hypertension without an obvious stenotic lesion. So the question was, did the aneurysm contribute to that? So what would you do, or how would you assess it? Because clearly there are 2 centimeter aneurysms, hypertensive people that are operated on, and that report that you had in ours that are cured, or certainly on very monotherapy, easy to take drugs. And my second question relates to the fact that these were all academic centers with a few exceptions. And the Southwest Texas group suggested that if you look at community activity and you look at the incidence of treatment of renal artery aneurysms, some 30% were done urgently with a diagnosis of a rupture. That's, we had ruptured aneurysms referred to us. We've never had an in-house or a local community ruptured aneurysm come. But 2 questions. How do you sort them out when there's a legitimate reason to operate on something less than 3 centimeters? And how do you deal with putting this fire about rupture and anxiety that the patient may have, or even occasional surgeon? How do you put that aside?
Sure. Well, as far as the relationship between hypertension and the aneurysm, I think what this study showed us was that it's definitely connected and that there's improvement. So I think that it can add to a decision. So as Keith pointed out, if you have a saccular aneurysm in a patient who's severely or hypertensive and not well controlled, then I think you could definitely justify it 2 centimeters, where if you have the same aneurysm and they're not hypertensive, then I would, in particular if they're not saccular, then I would let it go to 3 centimeters. The other thing is the complexity of the repair. And I think, as you pointed out and written some nice papers on this, as to whether or not those outflow vessels are all incorporated, and what the anatomy is really crucial in making that decision. As far as rupture, I don't know how to reconcile this study, which did have some community-based hospitals. Not all were straight academic, and were there no ruptures. I think I think everybody will agree that renal artery aneurysm can rupture, but probably that the likelihood and the risk is lower than we thought, and there is a risk to surgery. So I think you just have to weigh and discuss that with patients.
Peter, real quick before we move on, though, we're not talking about women of childbearing age, correct? Any woman of childbearing age should have it fixed.
Yeah, I think that although was a debate in the literature, I think that there's consensus that women should have their aneurysm repaired if they are either pregnant or of childbearing age.
I just don't want any trainees who are listening to get confused about this. Okay, go ahead, Peter.
Okay, the next one, Shireen Shaloub, who recently crowned Chief of Vascular Surgery at Oregon Health Sciences. And Shireen worked with us on a project on Ehlers-Danlos, which led to, I think, a grant, et cetera. And so she'll talk about the complexities of diagnosis and management of this uncommon disease, vascular Ehlers-Danlos syndrome. Shireen?
Thank you. So we learned a fun fact. When you start sharing, you can't unmute yourself. So we'll try that again. But I do appreciate the opportunity to present. And for the trainees, I think this is a great story of saying how, you know, when your mentors give you opportunities and you take them and you run with them, you can build an entire career on them. And so that goes back to the story with Peter, you know, where I approached him about this project early in my career. And Jim Black is on there. He's also one of these people who's mentored me. So here are some of my disclosures. These are all unpaid positions, but I'm heavily involved in the population of patients who are affected by genetic disorders that cause vascular disease. And what I'm going to cover here is the topic that you've asked me, which is the complexities of management and diagnosis in vascular EDS based on the Vascular Low Frequency Disease Consortium. And then I'm also going to talk about the lessons learned from there and how that evolved into the Veith's collaborative work, and then what we have learned about vascular EDS in the last decade. And it's an important reminder for people is that there are 13 subtypes of Ehlers-Danlos syndrome. And what makes an Ehlers-Danlos syndrome is a triad of connective tissue disorders that has joint hypermobility, skin hyperextensibility, and tissue fragility. Vascular EDS only accounts for 5% of all Ehlers-Danlos syndrome. So it's important when we talk about EDS that we're specifying what type of EDS we are talking about. Vascular EDS specifically is due to pathogenic variants in the type 3 collagen gene. This is the COL3A1, and it affects about 1 in 50 to 250,000 individuals. 50% of them are de novo. And there are major and minor diagnostic criteria that are well established and summarized in this reference that I included here from 2017. And the takeaway message is that these are great as a starting diagnostic point, but then we need to confirm the diagnosis with genetic testing. And that was the basis for the 2 papers that we have worked on with the Vascular Low Frequency Disease Consortium, where we wanted to evaluate the multi-institutional experience in vascular EDS. And the criteria was that they had to have genetic diagnosis. And we learned a lot from this experience, and we published 2 papers, one on the diagnosis and one on the arterial pathology. So the lessons that we've learned from the diagnosis perspective is that the eye doesn't see what the mind doesn't know. This is based on both my clinical experience with the patient population and then that work that we did when we did this study. So clinical diagnostic criteria really are a great starting point, but we really need to confirm the diagnosis with genetic testing. The other one from this cohort, you can see we had 86 people in that study, and not all of them had the major, not all of them, sorry, had the minor diagnostic criteria that have been described. And you can see that the most common criteria was easy bruising, for example, and then at 64%, and then thin translucent skin at half the population. The other thing is absence of family history cannot exclude the diagnosis, and indeed 50% of the patients are first in their family. Other things we've learned is that it is underdiagnosed in non-white individuals. So if you look at the studies, the majority of the population is of Northern European descent, and certainly you can diagnose vascular EDS in older populations. In terms of the distribution of aortopathy and arteriopathy in this population, it was very similar to the paper published in 2005 from the Mayo Clinic by Gustavo Oderich. So you can see that there can be widespread of the disease affecting every portion of the aorta and the arterial vasculature. What we took away from that experience is that there were several challenges in vascular EDS research, predominantly because medical records review alone without reviewing of the actual imaging was not enough to truly understand the clinical manifestations of the disease. And there remains the challenge of the genotype-phenotype correlation when the numbers in the study are small. And additionally, when people are brought up to the literature, they're usually brought up because they have a severe phenotype rather than a milder phenotype. And so consequently, this is the grant that Dr. Lawrence was mentioning, is we proposed to PCORI that we wanted to engage the population living with vascular EDS to understand their research priorities, as well as the optimal methods to study this particular rare disease. And you can see these are all the advocacy organizations that have come together and united under one cause to study this disease. And you can see that when we surveyed the population, 93% were willing to share their medical records to support research work in this area. And consequently, that led to developing the natural history study. It was called the Veith's Research Collaborative Study, and now we're rebranding it as a natural history study with my move to OHSU. And you can see that we harmonize data, not only data from people who are currently enrolled, but also people that I took care of personally, as well as people who were enrolled in the original University of Washington College and Diagnostic Lab, which was run by Peter Byers. We've learned that there are variation in characteristic facial features that that you can see, not everybody has the characteristic facial features. We've learned that thin translucent skin, as I said, can be present in half the population, as well as easy bruising. We also learned that vascular EDS is a progressive disease. One of the misconceptions is that the disease is sudden in onset and there's no way to predict progression of disease. While that is partially true, in several people, we're able to see progression of disease, which creates an opportunity for surveillance in this patient population. And so now the guidelines do recommend surveillance, and certainly happy to talk about that in the discussion. Other things we've learned is that vascular EDS has unique morphologic features where the infrarenal abdominal aorta tends to have the aneurysmal degeneration with sparing of a long aortic neck. And similarly, we see that in the iliac arteries in a basically what it looks like bell-bottom iliacs in that population. We also have seen the sex differences where females present with the disease later than male, meaning the manifestations of the arteriopathy and arteriopathy is at an older age among females compared to males. And across all vascular beds, the males are more likely to be affected than females, with the exception of carotid arteries. And that's due to predominance of carotid cavernous fistula among females. We've also shown that aortic and arterial repair in vascular EDS is feasible, particularly in the elective setting, and that the outcomes are better in the elective setting compared to emergency type settings. And this is a really important learning point, is that there is variability in the tissue quality. So there is this genotype surgical phenotype correlation where the genetic variant and type of variant is associated with the quality of the tissue as we operate on this patient population. And that really should form the basis for joint decision-making when it comes to surgery decision-making. In terms of repairs, what are the options? Endovascular repair has been well described in carotid cavernous fistula with embolization, as well as larger aneurysms. We've published this in JVSCIT, demonstrating a large subclavian artery aneurysm embolization. And then most recently, we published 88 cases with splenic arteriopathy in patients with vascular EDS using that larger platform of a natural history study. And among that cohort, we had 21 open surgical repair and 18 endovascular interventions, and basically learned that the outcomes are superior with endovascular repair. Most of these were since 2010, and most of them, the diagnosis was known. So led to superior outcomes compared to open repair in people who presented with rupture and in which the diagnosis was not known. We've also learned about the technical tips relevant to, again, the surgical phenotype that is related to the genotype. If the arteries have a more severe phenotype, they're more fragile, as you can see in this picture that I'm showing here with a ruptured distal aorta from endovascular manipulation. And this is the paper by Wei Lam and Jim Black had published a long time ago in 2012, a description of access. And this is an example of one of my access where we perform open exposure and repair of the femoral arteries. In terms of open surgical techniques, gentle manipulation is key. Felt strip everything during the repair, and gentle clamping are definitely key technical principles. And we've seen, again, we just published this in JVSCIT showing 3 open cases, and clearly the genotype dictated the quality of the tissue during this operation. But that extends into the question about whether or not EVAR is feasible in this population. We published this one case on a patient with a null variant where this patient and their sibling both were repaired with EVARs, and they had a variant that leads to 50% normal collagen, so a different type of subvariant that raises the question about whether or not EVAR can be feasible in some of the subset of the population. So in summary, the key to the VEDS diagnosis is recognizing it and confirming the diagnosis accurately. I've talked about some management principles, and really looking to the future, we want to think about molecular vascular surgery. This is the link to the VEDS collaborative that is still ongoing at OHSU, and there's the huge population of people in the village that helped put this together. And I really want to acknowledge Karen Wu, because she was a big supporter along with Dr. Lawrence when we did the original study with the Vascular Frequency Disease Consortium. And then this is the population that makes me get out of bed in the morning. I appreciate your time and attention, and thank you for the opportunity.
That's great, Shireen. And couldn't be a better person to discuss it than Jim Black, because not only has been a co-author on several of these papers, but also works at an institution that's had a long-standing interest in genetic diseases. Jim?
Well, Shireen, that was great. And, for those who are residents and students and haven't been around the block with a VDS patient once, the overview there was fantastic. I think as a surgeon, we struggle mostly with identifying which of the VDS patients makes you most nervous. And so perhaps you could sort of give us a little more of your own personal experience in that regard. And then lastly, and this is sort of building upon your collaborative experience, what do you think is the biggest gap between sort of what I would say, the frightening experience that it can be to manage these patients and what the patients say about the surgeons who are trying to give them information? Because oftentimes you're nervous to say too much, but you really got to say quite a bit to sort of frame the conversation in an appropriate way. And so there's naturally a gap, and your research really speaks to that.
Yeah, thank you. So in terms of the genotype surgical phenotype, I think that is the question, right, from a surgeon to say, who's the person I want to operate on and who's the person that maybe we should delay or approach in a different way. So the way I frame the discussions with the patients to say, let's start with saying, what would I normally do if this is average Joe coming into my clinic? So I use the guidelines, SBS guidelines for visceral aneurysms, for example, as a starting point, or for abdominal aortic aneurysms as a starting point to say, here's what we say for the general population. And then how do we frame that in your context of your own diagnosis? I definitely ask for the genetic diagnosis. We already know that people with null variants have better quality tissue compared to people who have amino acid substitutions. And within the amino acid substitutions, so this is for people who are maybe listening in on the genetics part, one of the most common variants in vascular EDS is something called a glycine substitution, where every third amino acid in the collagen chain is a glycine naturally in everybody. And in people with vascular EDS, glycine gets substituted by another amino acid, which impacts the folding of the collagen, and that translates to the structure of the collagen. So that's why the tissue can be weaker, if you will, from a scaffolding perspective. So if they have a large amino acid substitution, that will severely impact the folding much more than a small amino acid substitution. So just by understanding that biochemistry, you can start predicting what the tissue is going to look like. Now, this was all hypothetical for me when I started. Now that I've operated enough people, that bias is being confirmed and I'm seeing it. We also have natural history studies that show that survival varies by the type of mutation. So I think understanding the underlying variant matters in terms of your planning for the operation. So I am much more nervous operating on somebody with a large amino acid substitution. And in that case report that we published, the 3 cases of open repairs, I started with somebody who had a null variant, then moved on exon skip. And then the last patient we operated on was a large amino acid substitution. So we took a long time to come to that decision together. So I think that's important from a shared decision making. And I'm always happy to talk about these patients anywhere around the country if anybody has questions about their variant. In terms of the surgeon experience, one of the projects that we're interested in doing actually is to interview surgeons who've operated on vascular EDS, and particularly those who've had horrific experiences, meaning the classic story of like, oh my God, the tissue fell apart, right? I think that would be from a qualitative research perspective, would be very helpful to framing these future conversations to say, what is it that people saw? My impression is, again, if you show up with rupture or in a non-elective setting, or somebody doesn't know that they have vascular EDS, meaning you're operating like the normal way you would operate, I think that's what translates to these experiences. But that's one of the things we're interested in doing. And then obviously you have to be honest with the patients to say, there very well may be a risk of this tissue not holding, and then we may have to go to plan B, C, and D, and F. Thankfully, I've not experienced that yet with the ones I've operated on in an elective setting. And this is why I really think there's key to operating in an elective setting with knowing the diagnosis.
Okay, that was great. We'll move on to the last speaker and hopefully have time for discussion later also. Anahita Dua is a vascular surgeon from Mass General, and she'll be talking about a very controversial subject, factors associated with successful median arcuate ligament release in an international multi-institutional cohort. Dr. Dua.
Thank you very much. I also want to echo the sentiments of everyone. Thank you so much, Dr. Veith and Dr. Asher, for having me. And I also want to give a big shout out to Dr. Lawrence and Dr. Wu, who were instrumental in getting this successfully published. I have no disclosures relevant to this specific talk. And as was pointed out exactly, the introduction was given from me that this is indeed a very controversial topic. We have vascular surgeons that range all the way from thinking this is not really a disease process all the way to people who make their entire careers out of doing mals. It is a very elusive diagnosis. And what we know at this point is that about 24% of the population does have some type of asymptomatic celiac compression, usually diagnosed by CT scan, but actual symptomatic mals that really has to do with pain most commonly, and then issues with gastrointestinal mobility occurs very infrequently, about an incidence of 2 patients out of 100,000 people. So it's extremely rare. And yet we have this practice that some people, as I mentioned, have where they're seeing a significant number of patients. And the reason that we decided to do this topic is because at this point, there's really no way to appropriately diagnose which patients have it, which patients should have intervention, and who will be the right patient that may not need further interventions based on what you do originally. So that was really the impetus for starting this, this project. What we wanted to specifically explore is what small case series have really brought to the forefront, which were those biases. There are people that use laparoscopic techniques versus robotic versus, of course, open in order to release patients that have mals. And we wanted to look at a large cohort, by using the low disease frequency consortium in order to identify whether or not we can find patients where we can predict they will have a good outcome based on the type of surgery that they undergo. So as I mentioned, right now, there are 3 ways in which people approach these patients, and this is very anecdotal. People approach it based on, surgeons approach it based on whether or not the patients have particular anatomical features on the CT scan and the MRA. They approach it based on whether or not they have velocity changes based on ultrasound. They approach it based on just what they know, whether they can do an open versus a laparoscopic and some robotic surgeries, and then approach it based on patient factors. Essentially, this becomes a diagnosis of exclusion. So if you have a patient that has multiple gastrointestinal disease issues and they have maybe a questionable angle on a CT scan, a patient like that might end up undergoing a Mal's procedure. And so this is, of course, very variable. And this is tiger stakes territory when you're talking about the abdomen. So we wanted to get something out there that was going to be the seminal paper about the way in which these patients should be approached. So given that this is a low disease frequency, we did go to the VDF-DC and we did identify patients that had Mal's release from 2000 to 2020. We divided patients into the open, laparoscopic, and robotic groups. And we had primary and secondary outcomes, primary being essentially that a patient had no treatment failure long-term, or if they had no symptomatic relief from the original Mal's procedure. We did not count partial relief as a failure. If the patient had partial relief, even if that was sustained, that was counted as a win. And then, of course, if a patient had recurrence of symptoms, that was something that we documented long-term. And this was not a matter of technical success, which a lot of the biased single center studies do report on, because of course these patients aren't necessarily followed. This was looking long-term, what happens to these patients. In terms of secondary outcomes, we did look at perioperative complications, specifically ileus, and I'll get to that in a moment. And of course, the other standard secondary outcomes that happen surgically, like bleeding. And then from a long-term perspective, what we really cared about was reintervention, not what happened to those patients after they had the intervention, but just whether or not they needed a reintervention. We looked at Kaplan-Meier analyses and then did a Cox proportional hazards model to look at predictive factors for success. So in terms of our results, we had 24 centers across 7 countries, which is just an incredible way. So once again, a big shout out to the consortium. 516 patients were actually included in the study. We started out with about 528, but some lost to follow-up. Of that, the majority, by far, 44%, had an open procedure. We had 45% who had a laparoscopic procedure, and then we had robotic. And the reason I say the majority had an open is because we did do subgroup analysis, which I'll explain in a moment, where we combined open and laparoscopic and then compared that to robotic. Now, in terms of the results, to begin with first, when we looked across the demographics, we didn't really see any difference between groups in terms of the age and in terms of the sex. This is important because we didn't want to have any other factors that would ultimately shake out as a reason why patients had different outcomes. I do want to point out just again the breakdown. As you can see, this is an important point over here. The entire cohort, 516 patients, but open laparoscopic, and then very few patients undergoing a robotic. Though again, this is the largest series of this type of repair that's been reported to date. Very important to talk about competing diagnoses when you talk about patients that have Mal's, because there are many other competing gastrointestinal diseases that could potentially be responsible for the pain the patient feels. In our patient cohort, the majority of them that had a competing diagnosis had gastroesophageal reflux disease. Now, pain. So I want to talk about pain in 2 slides. Number 1, when we're talking about the actual presenting symptom, pain was most common, which is acceptable in the literature as well. And what was important is the location of the pain. So the patients actually ended up having epigastric pain most commonly, and then we broke it down by the quadrants. This became important later on when we looked at the results, because patients that have pain in various areas or pain that changes in location did not end up having a good result in terms of long-term outcomes. So it's a way to determine whether or not a patient might have benefit from MALS if they have pain in one location and that is sustained even when they represent, if they do represent. Specifically postprandial pain, as I mentioned, I want to talk about two things, was what was important. If the patient had exclusively postprandial pain, this is what I have listed here as a breakdown, or if the patient had non-postprandial pain, but the pain did get worse with eating. Of course, you know, SMA syndrome is another thing to think about in that case. And we didn't have enough patients that fit that to really break down. When I showed you the competing diagnoses, primarily they were GI in nature. Of course, weight loss, nausea, vomiting, diarrhea, other presenting signs and symptoms that come, but again, pain being the primary. Now, breaking down by operative variables to start with, first of all, the patients that had planned mesenteric bypasses or planned patch angioplasties in the original operation are listed here. Of course, the majority of them being in the open procedures. No patients in the laparoscopic or robotic had a planned mesenteric procedure. We did have patients that, as we followed up, had endovascular procedures in reintervention once they had their median arcuate release, but that is a different story. And those patients did do well from that once the ligament was released to be stented, but there was a very small proportion of those patients and not worth bringing up here. Another thing to point out for this patient population, there are a significant proportion of them were done by vascular surgeons, though there are general surgeons and other multiple specialties. Sometimes even now at Mass General, we have a thoracic surgeon who's doing MALS release, and then who just kind of has us present in case there is a vascular issue. And that doctor does it robotically. So just to throw that out there. In terms of the perioperative complications, as I mentioned, ileus was the most common, and of course, primarily seen in the open group. No surprise there, and easily can be managed with an NG tube. But bleeding and AKI, VTE also noted, but very small numbers. So essentially, really the point of this showing that the major kind of operative complication was just an ileus, not just, but an ileus that could be managed as with any open procedure. Now for the next two slides, the main results. First of all, talking about the initial benefit of having the procedure. Of the patients that had underwent procedures to begin with, first of all, these are the breakdowns who had freedom from failure as we move forward into approximately 3 years. The initial benefit was significant, but not all patients received it. And this indicates, of course, that we're not necessarily picking the patients that would get benefit. So almost half of them got no benefit from the procedure that, of course, is fairly invasive. And as you can see, as we move out further, laparoscopic, open, and robotic, patients tended to have over the 3 years the failure from treatment most commonly when they were in their laparoscopic group. But when we're talking about treatment in terms of reintervention, which is most important, we saw really no difference between the open laparoscopic group between the two, but we saw a major difference between the open and laparoscopic group when they were combined compared to the robotic. So the point is that whether or not a patient undergoes an open or a laparoscopic MALS release, they tend to have both a benefit when they are released if they're appropriately selected, and they don't go on to need a reintervention. But the robotic group does seem to have further reintervention rates, and that might just be a factor from the fact that not a lot of people do it. And of course, in this study population, we didn't have that many patients. What seemed to be the most associated with determining whether or not a patient would have a good result is if the patient had relief from a celiac plexus block. So if the patient was blocked and had relief, then that's a patient that potentially would have a benefit going forward, either with an open or a laparoscopic procedure. And really surgeon preference and surgeon confidence is what's really important in that. So overall points to make. Number one, the open and laparoscopic are fairly equal in terms of long-term relief, but the robotic patients are not having as good of an outcome. This is likely just because we have fewer patients and not that many people doing robotic at this time. And if we were to redo the study in 10 years, we might get different results. Laparoscopic patients have fewer perioperative complications, but they do have more reinterventions, but those reinterventions go on to have good results. So if you end up stenting a patient down the line, they do have good results. The celiac plexus block is the most helpful prognostic tool. And of course, we need further studies on this to determine whether or not MALS patients should be treated and who should be treated. Thank you.
Yeah, Dr. Dewar, that was a really terrific overview. And real quick before Dr. Dietzig asks his question, I have to say one thing that really struck me is one of your first slides where whenever I see these patients, I'll always say to them who are referred to me, I say, you know, there's thousands of people who have this celiac artery compressed and they don't even know it. But now I'm going to tell them 25%, 25% of our population has a celiac artery compression and they're asymptomatic.
That's right.
That's a real teaching point, I think, for trainees and the audience also. All right. Anyway, Dr. Alan Dietzick, who's director of the Vascular Service Line in Danbury, will ask a question. Alan.
Anahita, that was a wonderful presentation. And as you mentioned from the outset, this is an extremely controversial disease and diagnosis. So the things that I would ask you, first of all, are what diagnostic, because it's a diagnosis of exclusion. So what diagnostic tools are most important in making this diagnosis? Do you believe this has a vascular etiology or a neurogenic one? And finally, for those, many of the patients that are being operated on today are young women. And as you know, much of how these patients get referred is through social media. Once you post online that you're doing this operation, you will get inquiries from all over the country and the world, because so few people want to address this issue. So in the younger population, should there also be a psychiatric evaluation prior to intervening on these patients? So I know that's a lot of questions, but see if you can answer them.
These are great questions. First of all, I'll start with your last one. So interestingly, in the paper that we published as well, we discussed this because exactly like you said, the psychiatric component is there. I mean, this is our equivalent of fibromyalgia, right? But for vascular. And so indeed, that is a problem. And in our patient population, we had up to greater than 20% of our patients had some history of psychiatric disease. Now, not specifically with pain and issues with pain, but just a psychiatric component. As you saw from the study as well, females did make up the majority, though our patients, globally are a little bit older than what I had expected when I started the study. In terms of the diagnostic criteria, number one is multiple sessions in the office, taking a history, thorough history, to begin with, specifically trying to rule out all the other causes that may be associated with pain in the abdomen, which is really what they're presenting with. But when we move on to diagnostic modalities, we use inspiratory expiratory ultrasound. Of course, that has to do with how good your vascular lab is. And, at what point at our vascular lab, we had a point where they were doing these studies and we had a lot of mals being diagnosed. And then we figured out that they weren't standing the patients up to do, because you have to do it in a standing and lying position. And we discovered this. And so patients were actually getting operated on with, incorrect diagnoses. I will point out, as a side note, I didn't talk about it in my talk, but we did actually explore pretty thoroughly in this paper whether or not there was a difference in the imaging modalities and whether that could be predictive of whether a patient did well. We looked at the angle of compression and we looked at the PSV, again, inspiratory, expiratory, using 200 and using 350. So the two accepted ways, and there was no predictive value to it. So other than just trying to make your case, it alone is certainly not diagnostic. In your third question about whether this is neurogenic or vascular, I have also been converted, albeit anecdotally, but I'll say that there is a neurological component, because the patients, especially in the robotic ones, at least anecdotally that I've been for, if the robotic dissection is pretty extensive and they really get that plexus and really cut through those nerves, the patients seem to have a benefit, at least temporarily. Now, I don't know if it's scars and then they reform and have problems again a couple of years down the line, but certainly immediately, if we really get, so it's not a matter of just cutting that cruce and hoping for a little bit of release. You have to really get down onto the vessel and cut all of the nerve essentially that feeds that entire area. So I don't have a direct answer for you. Certainly don't know from this paper alone, but it seems that is the major component of it.
Yeah, I would tend to agree. And but what is frustrating is that, as you showed, I believe that at 3 years, approximately 50% of the patients come back with recurrent symptoms. And so you would think that if you're removing the celiac plexus. And of course, you need to do a celiac plexus block prior to intervening on these patients. But if you then remove the celiac plexus, why do not 100% of these patients get better?
Right. And I think that I know this is being recorded, and how this will bite me in 10 years, I don't know, but there must be some psychiatric component to it. I mean, I think, one of the ways to think about these patients, and one of the reasons I did this study just personally, is we did have a patient, wasn't my patient, luckily, but a patient that very young, like 22, something like that, started down this path. And at this point has had, she must be on her third or fourth surgery, major surgery, multiple, now we're doing like hepatic bypasses and like things of that nature. And this woman is just so, and she's going to pay for this. Like 50 years from now, she may die from this because we started her down these paths, and it was the wrong diagnosis, clearly. But now you're in it. And so every time she comes back with those same symptoms, my partner just is kind of forced to take it on again. And it's clearly not the right thing to do, but what are you supposed to do at this point? And so I think it's important to have this sort of data out there so that we can defend ourselves when you have that patient, crying in your office, and you really have to say, no, this is the wrong thing for you.
Yeah, I think
I don't think that Dr. Ditsky is too enthusiastic about this type of operation, but maybe it's my impression.
Well,
I have a question for a quick question, because we have only a couple of minutes. I would like to have a question for both Dr. Stanley and Dr. Lawrence about the fact that 50% of the patients, despite repair of the renal artery aneurysm, they continue to have hypertension. I'm assuming that these patients did not have essential hypertension. That was something related to the aneurysm. Do you think that one of the etiology could have been prior embolization, microembolizations, and that could have caused the continuing hypertension?
Jim, go ahead.
Yeah, so I don't think that's common. It may happen. We actually did some hyper resolution conventional arteriograms, and we very rarely would see a small segmental artery, second or third order branch that had been occluded. So I don't think that's the issue. And actually, just to the opposite, is that many of these people are better because their drug management is better postoperatively. They come in with all sorts of regimens. So it's a mixed bag. But when I asked Peter that question, Peter said some 2 centimeters with difficult to control hypertension maybe deserve an operation. I was hoping that we'd try to analyze whether they were making renin in excess, whether there was evidence of collateral vessels around a compressed branch, exiting branch, or what have you. I think this is a much more complex question, and you can rob the bank and get away with it in some patients, but these operations should not be undertaken, just because somebody has easy to control hypertension, but they've been on 2 drugs for 10 years. And I don't think essential hypertension. Most of these patients are pretty young. The majority are young.
Okay. Dr. Shalhoub, just a quick question. I have amazing talk, really fantastic. How easy is to get our patients the ability to have a genetic profile when we suspect? Because it seems to me that it's difficult to get them approved by the insurances. Second, it's hard to find a place that's accurate enough to give us results that helps us make this decision.
Yeah, that's a great question. So in terms of the insurance, I will say that it has gotten better over the last decade compared to when I first, maybe even 15 years ago. And part of that is because the guidelines, now we have the we have the AHA guidelines with the ACC guidelines that just came out that clearly spell that out. And so now what we do is you just send a copy. If they deny, you just send them the copy and say, we need to rule this out. And then also with the documentation, you want to document that this will make a difference in your decision making and why this testing result is important. So I think improving documentation matters. I think the insurance companies are getting better. So that's one thing. Sometimes they still deny and we have to write letters, but that is an area we're still working on. The other thing is how to make it available, because not everybody has a geneticist on staff. And in fact, in the United States, there's a shortage of geneticists, and there's a shortage of geneticists who have arteriopathy training, even among genetic counselors. The commercial companies do have people. I've actually was talking, I don't know if we're allowed to say this, but I was talking to Veith specifically recently to say, how can you become more visible to our vascular surgeons at SVS and other meetings to make them aware, just like industry has trials and availability. How can you, as a commercial company that does genetic testing, make yourself available so that you can do this? They can get you a quick turnaround, meaning maybe about 2 to 3 weeks turnaround, so it's still not immediate. Ultimately, I'd love for this to be much more readily available in 10 years from now. But right now, there are commercial companies that you could potentially use if you don't have somebody at your institution. Lastly, University of Washington, Peter Byers is still there, so he will see people, that way to get testing through that. And I'm working with my team here at OHSU so that we can also do genetic testing here as well.
Thank you. I'm only sorry for those who did not attend this webinar. It was one of the most complex and interesting ones. I took so many pictures here, I can write a book about it. Thank you so much. I want to certainly thank our moderator, Dr. Lawrence and Dr. Caligaro, and these great speakers and discussions. I think this one is one of the top webinars we've ever had. Thank you so much. And we're going to bring this group again, I'm sure, in the near future. Thanks a lot.
Thank you.
Have a great weekend, by the way.
You
too.
And thanks to Dr. Veith, our mentor.
Yes.
Thank you.
Bye.